So this is my presentation on applications of artificial intelligence in healthcare. And before that, I would like to introduce myself. I am Professor and Dr. Shabbir Syed Abdul from Graduate Institute of Biomedical Informatics. And the key issues in healthcare, which we are going to focus and by where we want to use artificial intelligence to solve is these are the three problems I can say or key issues, that is medical errors, poor and inconsistent quality, one size fit all prediction and prevention. By medical error, I mean all various type of errors. It's not only human error, but also it's related to the systems, it is related to the drug dispensing and what all various type of errors possible when we are providing care for our patients. Therefore, it can be very important topic of patient safety in the sense. Then second thing is like quality. Again, poor quality is how we can improve our quality by using artificial intelligence. Because you need to understand, healthcare is nothing but it's all about information, the how information we are going to use. So therefore, what is artificial intelligence? Let's begin with the definition. Intelligence is nothing but the way we think, the way we reach to logical conclusions. So that is why we called, okay, we need to have like algorithms. Algorithms is nothing but the steps, how we are reaching to our conclusion. So let's start with how we used to work before with the systems, because computers are not new. We are using computers from last 40, 50 years, but from last 20, 30 years, very much we are using it. Therefore, to begin with, we started with the rule-based inferences. Okay, if you are 40 years, if you are female, okay, you need to have this type of investigations. If you are male and if you have this problem or if you are taking this medication, then you have to undergo these blood examinations. In that way, we are actually giving a rule-based inferences to the systems. Then comes probabilistic inference. If these two things are combined, then we should do this. If these two diseases are there, then you have high chances of high risk of getting the third disease. So that is called probabilistic inferences. And third is statistical modeling. Basically, we use a lot of statistical modeling in last 20, 30 years for doing various type of calculations, estimations, survival analysis, prediction, odds values, hazard ratios, all this is nothing but statistical modeling. But now also there are like ad hoc scores, like Apgar score, like glaucoma score. So what I mean to say is there are various methods by which we were trying to come up to reach our logical conclusions using this type of methods. But lately, when the computation power has increased, when the data collection has increased, then we thought of why not we train computers and then we ask them to provide us some sort of assistance. So here comes machine learning. Machine learning is nothing but we are teaching machines or your computers how to analyze the data which we are providing and how to help us with decision making. So they are just providing, assisting us. So ultimately, the responsibility of what decision you are making belongs to yourself. Okay, then comes these neural networks, support vectors, random forest. There are like plenty of different machine learning methodologies where we provide data to the machine and ask them to learn from the data which we have provided. Then we start asking questions to get some sort of answers from the computers. And for various purposes, we have different methodologies. Of course, we cannot discuss everything, but I try to reflect some things, some methodologies. The one of them is neural network. Neural network is nothing but we train computer as our brain itself. How the neurons are passing the information from neurons to neurons. There are like some billions of neurons in our brain. So the way whenever we see, whenever we hear, whenever we touch, all our sense organs, it collects the data from the way we are for currently you are listening to my voice, then it's going through your what to say eardrum, it's going to your brain, there comes the signals, then the signal your brain is processing the signals and making a sense out of it and giving it to your conscious or for your understanding part of your brain. In that way you are understanding exactly what I am saying. But here what I want to emphasize is it's nothing but passing of information from one neuron to another neuron till it makes some logical information by using some processes. So that is exactly what we are using in neural networks, where we pass, if you see, from one point to another point, one point to another point, then we are classifying, then at the end we are saying, okay, if you see on my on the left side of the slide, it's car. Then we are taking each bit of this car, each byte of this car and trying to process. And at the end, we are giving computer saying, okay, is it car, is it truck, or it is a van or bicycle? So it can be say many other things. That answer we are providing to the computers. Then after giving various colors of cars, various shapes of cars, various angles of the positions of the car's images, then we teach computers, okay, how the car looks. So next time when you show the picture of car, the computer can recognize, oh, okay, this is a car. Same things happens for other type of things. So now same things you think about our diseases. So instead of car, we are keeping X-ray or MRI or any information about the patient. And then we are analyzing same information till the end and saying, okay, whether this patient has cancer or not, whether the patient has some X disease or not. That is how we are teaching computers. Then what I do is I will discuss some very interesting projects from Taiwan, and especially the next project is about My Health Bank. You might be knowing about it. If not, I strongly recommend you to Google about it, because this is one of the fantastic project I have seen around the world where government has given access to their own information to the public. Personally, I can, like anyone in Taiwan who have national insurance card, can log in into the system and see what's happening with them, their specific disease patterns, and then they see what are the risks of cancers and chronic kidney disease for them. So what is happening here is the government, as you know, wherever you go, any hospital, whether it's private, it's public, or you go to GP, all your information goes to one server. And there is a record of yourself. Like this is an experience from Taiwan National Health Insurance Research. Data demonstrate that cancer patients have a specific disease patterns, and the patterns can be discovered from EHR, electronic health record, longitudinal data by machine learning models. The models can predict cancer risk according to the medical history of clinical diagnosis of each individual. So here, these type of models can be useful for personalized prevention and cancer prediction and medical history of clinical diagnosis. Same thing applies. So instead of these, if you see, these all are variables, all your diseases, medications, lab values. At the end, the machine, the computer will know whether you have cancer or not, whether you have at risk of developing cancer or not, whether you are at risk of developing chronic kidney disease or not. So here are two examples. Actually, this is from my own web page where I predict my own liver cancer prediction. So if I have given my age, my gender, then and my GPT values, all those things, then they will say, okay, AORC for next 5 to 10 years is like 82 to 80, 84 to 82%. So I have less than 1% of risk in next 10 years. So this gives, so if someone has cirrhosis, if the age is more elderly and they have alcohol or cirrhosis or hepatitis, then the risk of developing hepatocellular cancer will be much higher. That's how you can see your own risk of getting cancer. By seeing this, you will be motivated to change your behavior, to stop things which are bad for your health, and to modify your lifestyle to a healthy one, so that you can at least prolong the onset of your cancer. That means instead of getting in next 6 months, you can prolong it to next 2, 3, or up to 5 years, depending upon how strongly you are modifying your health behaviors. That is one thing. Next important thing is, once you know you are at high risk of getting cancer, then you can do early detection. Because early detection is very important, because when you early detect any cancer, it's easy to treat with less pain, with less money, and less burden to care providers. So these are two win-win situations for us. One, you can prolong onset of the disease. Second, you can early detect the disease. And my health record, this is what we try to do in India, because we have like online healthcare consultancy. Because of this corona COVID-19, people are hesitating to visit hospitals. Therefore, Indian government have started online consultations, where we wanted to have this type of applications, so that we can predict a personalized prediction of some serious diseases. And principles are the same. And in addition to just using clinical data, what we can do is that we can use AI-based personal health record systems. By personal health record systems, we are including data from wearable and IoT devices, so that we can provide more rich data, more granular data, to do better predictions, to do more personalized or precision medicine decisions. And then we apply deep learning for these models and do the same thing. So here, same thing, we use wearable device plus clinical data, and then we do some analytics. We provide clinicians with the models results. So I think these things we don't need to know. We know how we can initially design the data set, how we validate, and then how we test all those things. So therefore, what we wanted to do is scale up existing health record to artificial intelligence based PHR for risk prediction, understand the causes of cancers by seeing their clinical history, develop models to compute risk of getting cancer actually, and develop IoT based solutions, so that we can monitor the patients from distance, and we don't need patients to come to hospital every frequently. Then this is the project where we H 2020 project, European projects, which we have where TMU is partner in that consortium. This is also about holistic health records and big data analytics for health policy making and personalized health. Basically, what we did in this is we want to provide data-driven evidence for policy making, because so far all our clinicians only depend on evidence-based medicine. Evidence-based medicine is nothing but you need to what to say make the research on one particular topic with huge number of patients, and this is very time consuming, resourceful, full, you need lot of money, lot of people, and it takes so much of time. Therefore, what we want is we want to use data to come to some conclusions, to provide evidence. So these are the partner of this consortium, like Karolinski Institute from Germany and Europe, Germany, Siemens, and TMU also is part of this project. So just we wanted to provide a snapshot how it happens, information acquisition, because health data is so heterogeneous. Heterogeneous in the sense we get from various sources in various format. In some can be numbers, some can be alphabets, some can be text, some can be images, some can be sounds. So it's lot of heterogeneity in the data and various data sources. Then we want to make collective knowledge using this type of data and provide these social holistic health records. Then evidence-based policy evaluation, big data management, data governance, reliable information, data visualization, and analytics. That is what exactly we wanted to do. Okay. I just skip this because the main purpose is this. The whole platform consists of lot of plugins of various modules, how we should do using our holistic health record. So I don't want to go in the details because of the time constraints. But overall, what we want to do is, okay, we had like 6 pilots from various things. TMU is part of chronic kidney disease along with Karolinski Institute. Other we're doing on public environment. Some were working on living labs, social networks, chronic diseases, and health centers. So there were like 6 different groups working on 6 different these things. And at the end, we need to develop toolkits for developing a policy by data-driven evidence modules. So again, today we were using numerous health ICT services, but next we want to make policies exploiting big data. That is the key. Heterogeneous data sources, holistic health records, data analytics on aggregated data, and exploitation of collective knowledge and multimodal targeted policies. So then I just go through some of the research because I have only 8 minutes left, where we used machine learning models to predict initiation of renal replacement therapy among chronic kidney disease, because it was very interesting to see at what time we should start dialysis, at what time we should go for transplantation, because that gives the outcome of the patient. Obviously, if you guys are interested, please go through these papers. I just go through with the results and some part of methodology. So what we did is our aim was to predict the outcome of renal replacement at the time of diagnosis. So what we want to see is when this patient is likely to start hemodialysis. We define CKD diagnosis time as the day of the patient in the first diagnosed with CKD. Patients are then followed for next 24 n months with n equal to 12, 6, and 3 months prediction period. For each of 3 values of n, if hemodialysis or kidney transplant occur with this n month, the patient is labeled as 1. Otherwise, 0. Then we predicting patient's outcome only data prior to CKD time is taken into account. So this is exactly how it works. So in short, we were able to predict in next 3 months, 6 months, or 12 months of hemodialysis given current status of the disease. So these are the details of those disease, and we got very good at least I cannot say like 77 is very good, but it is good for public health. purpose, not for precision making, for resource management, but not for person per se. For personalized medicine, we need at least 85 and above. But here we got like, okay, what are the very important values, parameters which are predicting hemodialysis in the patients. So use of comorbidities to predict renal replacement therapy in predicting the chance of upcoming RT based on clinical data using predictive model on general population with data available can allow for better planning and allocations of resources. The second research was on detecting blood cancer using cell population data. Cell population is nothing but complete blood picture. So here we use like 551 patients with blood cancers and another 400 patients, 400, 500 patients without cancer. And then we compare their complete blood pictures and we got this type of results. And I think results were pretty much good. Yeah, you see, the results was like 93%. So by artificial neural network. So this is what we need. When the values are above 90, it can be clinically useful. Otherwise, it will not be so much useful. So conclusion, ability to predict hematological malignancies and hematological non-malignancies with accuracy of 82 and AOROC of 93, outstanding performance results on ANN, and we published this paper in scientific results. Reports. Then the third research is about artificial intelligence based prediction of clinical events among hemodialysis patients using non-contact sensor. This was again interesting research where we use this pad, if you see, which was kept below the mattress. That means there is no contact of sensor with the patient at all. However, we can see a heart rate, respiration rate and movement. You see 78 is the heart rate, 21 is the respiration rate, 0 is the movement. If the patient is not moving, it will show 0. If the patient is moving, it shows 1, 2, up to 2, 3 digits. That means 3 means it's so much restless. Patient is restless. So this we collect when the patient is undergoing hemodialysis on the bed. So patient has to lie down on the bed with this sensor under their mattress. The patient will not be knowing, it will not be connected directly, but data will be collected. And then we wanted to see by using these three parameters, respiration rate, heart rate. From heart rate, we estimate heart rate variability, you see, by using that, whether we can predict one of these clinical events. Either sudden death, emergency visits, muscle spasm, inpatient admission, or ER emergency room visit, or no. So in that way, again, what to say? The prediction value was 85% to say whether next 2 months or 1 month the patient will have one of these clinical event, this one. So it was again published in Sensors. So here is the result. So we wanted to use non-contact sensors in clinical settings to monitor the vital parameters of patients, develop of early warning solutions using artificial intelligence for prediction of clinical events, and assist healthcare professionals in taking decisions and designing better care for patients by early detecting chances to clinical these things. And this is my last things where we are using health reminder systems on eye change behavior. This was another H2020 projects where we were sending messages to the people who are interested in quitting smoking. You see, this is the dashboard. This aid shows since 8 days they stopped smoking. 49 shows in these 8 days they have not smoked 49 cigarettes, if they were continued to smoke, they would have smoked 50 cigars, and how much money they saved in euros and how much health they saved. And this is the message they are getting. So this paper was how the messages, personalized messages, can help people in motivating in quitting the smoking. So definitely it helped in personalizing, because we are sending computer tailored technology, single what to say, digital health solution for smoking cessation. So maybe I show the more results, because the messages were not randomly, it were more personalized depending upon age, gender, and what to say, with whom the people, circumstances the user is living. For example, if you are living with kids, we can say, okay, 8 days you didn't smoke, please continue to abstain from smoking, because your child will be becoming more healthier if you stop smoking, stuff like that. So this is how it works. So implementation and development process of health recommendation system using I change behavior model to help quit smoking, application of AI based algorithms to digital health solutions. So these are like few examples what we were doing in last 4 5 years, where we used AI intensively to provide various assistance for various people. So these are my experience using AI. So I will be more than happy to take questions from you.